Going to be speaking about electrolytes in burns, and this is a massive topic, so we're going to deal with each of them individually over the next couple of weeks, and today we're going to be speaking about magnesium. We're first going to be looking at a summary of the post-physiologic and metabolic changes that occur. We're going to look at electrolyte changes in burns, and then we're going to specifically look at magnesium. Tissue thermal damage induces extensive metabolic and physiological disorders in burns patients. And a burn does not only injure the skin, but due to the inflammatory response, it actually essentially results in a whole body injury. And the most important of these changes is the hypermetabolic response, which, in addition to hypoxia and inflammation, changes the direction of energy metabolism. And this then alters the usage of electrolytes as well. And you can see from this picture that they all interlinked, all the responses to the burn. So the hemodynamic response is influenced by the hypermetabolic response. The hypermetabolic response influences energy and lipid metabolism. And all of these affect the electrolytes as well, and the usage of electrolytes and the metabolism of electrolytes in the body too. In the acute phase following a burn, it's not uncommon to see patients becoming hyponatremic, and this is due to extracellular sodium depletion following changes in the cellular permeability as a response to the burn. They're also occasionally seen to be hyperkalemic initially, so you'll see we don't as aggressively respond to hyperkalemia in the acute phase post-burn as other people do with other conditions, and this is due to cell lysis and tissue necrosis, so we often see patients with a slightly higher potassium than you would expect normally. In the post-acute phase, patients often become hypomagnesiemic, hypophosphatemic, and hypocalcemic, and we're going to be discussing each of these individually over the next few weeks. Looking at magnesium just in general, it's the second most abundant intracellular cation. It's mainly stored in the bones, and the magnesium concentrations in the body is regulated by intestinal absorption and renal excretion of magnesium. So even though less than 1% of the magnesium occurs in the serum, it is the only surrogate marker that we have for magnesium. So while it's not an ideal marker, that is unfortunately how we have to measure magnesium, and it's not a great representation of total body magnesium, unfortunately. Looking specifically at magnesium in burns, hypomagnesemia, as I said, is not uncommon in the post-acute phase, and it usually correlates with burn severity. So the severity of the hypomagnesemia, or how many times you have to replace the magnesium, correlates with the severity of burns very often, and it's often associated with hypocalcemia and hypokalemia. So there's no point in looking at individual electrolytes on their own. You need to make sure that you do a UNE and a CMP together to try and correct all the electrolytes if there are electrolyte abnormalities, because one influences the other. Magnesium is involved in lipid metabolism, control of blood pressure, carbohydrate and protein metabolism, nerve conduction, oxidative phosphorylation, and the transport of potassium and calcium ions. So magnesium plays a role in many, many systems in the body. So it's quite an important electrolyte, even though it's often forgotten about. Reasons for hypomagnesemia in burns patients, firstly, is excessive magnesium losses, and this can be through the burn exudate. So if you've got a very exudative wound, you might find that the patients become more profoundly hypomagnesemic, and those patients need to have their magnesium aggressively replaced, because they are going to continue to lose the magnesium until the wound is closed. Patients may have excessive renal losses due to glomerular necrosis, and this glomerular necrosis results from hypovolemia and shock in the initial phase if the patients aren't resuscitated adequately right from the beginning. Endocrine abnormalities that may result in magnesium losses can be high cortisol and high aldosterone from the SIRS response associated with burns. And it's not uncommon for burns patients to have thyroid and parathyroid hormone derangements, and these can also influence excessive magnesium losses and renal excretion of magnesium. Other causes of low magnesium in burns can be the hypermetabolic response. So because of the increased metabolism or basal metabolic rate, there are increased magnesium requirements and increased uptake of magnesium into the cell, so that can result in hypomagnesemia. Certain drugs such as aminoglycosides, proton pump inhibitors, and diuretics all influence the renal excretion of magnesium and can increase the renal excretion, resulting in hypomagnesemia. Patients that have been sitting at a base hospital for a prolonged period of time with a large burn and haven't been receiving additional or supplemental feeding, such as NG feeds, can develop refeeding syndrome when they present to a center where they are started to be fed, and that in itself can result in altered magnesium metabolism and hypomagnesemia. inadequate intake of magnesium, and feed intolerance. So you'll have heard in the previous tuts that diarrhea and vomiting is a common symptom of sepsis in Burns patients. So when patients are septic and they have feed intolerance, they may not be absorbing magnesium and they may be excreting it incorrectly, and as a result they may become hypomagnesiemic. And patients with low albumin may represent or present as hypomagnesemia as well, because a portion of the magnesium is albumin bound. So in patients with a low magnesium, it may reflect as hypomagnesemia on the blood results. In the anabolic or flow phase of the hypermetabolic response, patients may have increased uptake of magnesium for protein synthesis, and this can present as patients with persistently low magnesium despite aggressive IV magnesium replacements and an increasing albumin. So with those patients, you just need to keep replacing the magnesium and keep monitoring the magnesium as well. So this just summarizes the reasons for low magnesium in burn injuries. So the hypermetabolic response results in an increased demand. Patients who have that get aminoglycosides, diuretics, or PPIs, it alters the renal excretion. Stress hormones such as cortisol and aldosterone also influence renal excretion, and shock and hypovolemia in the initial resus phase can result in glomerular necrosis, which also alters renal excretion, and all of these can result in hypomagnesemia. Hypomagnesemia can cause the following manifestations. So neuromuscular manifestations, they may have seizures, weakness. The Burns patients are often weak on their own just from being bedbound, so this might not be so obvious, but it can contribute to patient weakness. Patients may be apathetic and not be super keen to get involved in therapy. It may result in delirium, have cardiovascular manifestations. It may result in hypokalemia, so a patient who is struggling to get the potassium up. If you check the CMP, you may find that the patient has low magnesium that you need to replace as well, and then the potassium will respond. And they may also have abnormalities of calcium metabolism. The management of hypomagnesemia is magnesium sulfate. In kids, we give 50 milligrams per kilogram in 100 moles of Ringer's lactate at 5 moles an hour, and adults 4 grams in 100 moles of Ringer's lactate at 10 moles an hour. But if the patient is fluid restricted for any reason, consider mixing it in 50 moles of Ringer's lactate and then halve the running rate. So for children, it'll be 2.5 moles an hour, and adults 5 moles an hour. Hypermagnesemia in Burns is exceptionally rare and is almost always associated with significant renal failure. The management of hypermagnesemia is to stop any parenteral sources of magnesium, to support the ABCs, so they may have cardiovascular manifestations and may need to have cardiovascular support. You need to dilute the serum magnesium concentration with IV fluids, and if the patients are symptomatic, you may need to antagonize the effects of the elevated magnesium with calcium. So you can either use calcium chloride or calcium gluconate, depending on which is available at your facility. So the take-home message is that you need to monitor electrolytes in Burns patients. They're exceptionally important, and you need to aggressively replace them. The requirements of electrolytes changes from the acute phase throughout recovery, and you need to change your practice to be cognizant of the fact that electrolytes are important and actively monitor for electrolyte abnormalities and then aggressively replace them. If you don't act on blood results when electrolytes are low, you're not going to change anything. So make sure that you actually monitor electrolytes and that it becomes part of your routine practice to check on them and to replace them. Thank you very much.